We'll be talking about complex mitral valve case next, and kind of as I'm going through the case, everyone on the panel, please, if you have questions, comments, please chime in. So this is a 67-year-old, history of a prior CABG, mitral valve repair 4 years before presentation, and then underwent a redo mitral valve repair 2 months prior to presentation. With the redo mitral valve repair, my understanding is that it was a very difficult surgery. There was a lot of trouble repairing the valve, and so they ended up, in the end, placing an alveoli stitch. Dr. Gillenov, how often, or what leads to this scenario where you go in for a redo surgery and you come out with an alveoli stitch?
Never.
Okay, so this is the N of 1 right here then.
What, did I do this?
No. This is we didn't go and find the single skeleton in the closet of the secret alveoli stitch that you went in. So it was a little bit of a surprising scenario when the patient came to us.
I think it's a good thing that at least we tried once and they send it again to do the same procedure.
Yeah.
Basically, that alveoli stitch by putting a clip. So it was a very unique patient.
I may add that Dr. Alfieri is advertising a mitral tear course for 3 days. So he's working together with interventional cardiologists to advocate for the mitral tear instead of the stitch.
It's this was a little bit of a surprising scenario for us. So several weeks after surgery, he started noticing some shortness of breath, jaundice, dark urine. He had anemia. He had an AKI. And then he had some fevers, and so he was started on empiric antibiotics. The fevers eventually went away, but a little bit of a confusing clinical scenario. Eventually, after a very, very extensive workup that he had locally, he was diagnosed with hemolytic anemia. And when he was transferred to us, we were told that his echo showed normal LV function and moderate mitral regurgitation. There was a question of whether he possibly had endocarditis, so we really weren't sure exactly what was happening at this point. The patient was really having trouble at his local institution, was requiring a lot of transfusions, renal function was getting worse, oxygenation was getting worse, so he eventually was transferred over to us. So when he arrived, his vitals were really significant for an oxygen requirement, 4 liters. He had signs of heart failure on exam. He had a very loud, harsh systolic murmur. And then labs notable for a hemoglobin of 8.4, creatinine of 2.6. His baseline was 0.9, high LDH, low haptoglobin, and EKG was okay. So next step, of course, we went to get an echo. And so what we can see on the surface echo here is that you'll notice right away that it looks like there's possibly some SAM, there's some mitral regurgitation, and a lot of turbulence in the left ventricular outflow tract. So our LVOT gradient was very high, 142, because the patient also had mitral regurgitation. There was a question of could we be getting some of the MR jet. When we put a CW through the MR, we got a very high gradient, 296, so that really tells us that this was true LVOT obstruction that we were catching. In the first 24 hours after he was transferred to us, hemoglobin quickly declined down to 6.8, platelets getting worse, again, bilirubin going up, creatinine going up, and BNP high. So he went for a transesophageal echo, and you can see really nicely here we've got significant mitral regurgitation. We have severe SAM with septal contact. And on the 3D imaging, we can actually see where the alveoli stitch probably was previously placed, but is no longer attached to the anterior leaflet. And here's some 3D images really lined up on where the mitral regurgitation is, which also aligns with where we noticed the severe SAM. Gastric images to be able to see the SAM and look for LVOT gradients. As you see here, again, very high in the 160s for LVOT. And then just kind of a fun, cool image that we have here. If you're in the aortic valve and looking at the LVOT, you can actually see the anterior mitral leaflet, both in diastole and systole, is almost completely obstructing the LVOT. Things continue to rapidly decline. We're actively transfusing. Creatinine's getting worse. Nephrology actually said we need to start preparing for dialysis because he had almost no urine output. And so, of course, the whole mitral team was involved. We talked to our surgeons. who felt that a surgery was likely going to be, difficult at this time. Third time re-op, there's patent lima, renal failure, and then the timing was, within the first, 2 months after surgery. Dr. Gilinoff, can you comment, what is that, ideal, if you have to go back into the chest, what is the ideal time? It's very early, very late, somewhere in the middle? Like, this is something that sometimes comes up, is the timing of when it's needed.
The ideal time is very early or late, very early being within a couple of weeks, and then late being more than 3 months.
Okay.
So this would be a bad time.
Yeah, I think that was one of the main driving forces, is that this was not going to be a good time to go back into the chest, and the patient's presentation was kind of declining very rapidly, so it wasn't a scenario where, we could wait a few months. Yes, Dr. Kapadia.
I had a question for Mark, because I think that the reason why they put the Alfieri stitch was because of the SAM, that they may have feared that this would cause a SAM. So in a way, this is a good situation for considering this is what our thinking was, that if the surgery worked by putting an Alfieri stitch in the first place to prevent the SAM, then it makes sense that now putting something similar to Alfieri stitch, which is a tear procedure, would help in this situation. So I want to know that when do you put an Alfieri stitch when you have SAM versus you have some other methods of treating the SAM during surgery? And what is plus and minus of those?
I would tend to treat the SAM or prevent the SAM in a different way. At that second operation, if I were doing it, I would have taken down the repair and shortened the posterior leaflet. SAM after mitral valve repair is always caused by too much posterior leaflet tissue. That said, an Alfieri stitch is a quicker and easier way to do it unless the stitch tears out like it did. And I think the stitch if you do an Alfieri stitch, it's got a lot of variability how you do it. And I think on average, a clip or a Pascal is probably better than a stitch in this regard.
Yeah, maybe a couple comments from my end. I think, again, to Dr. Gilinoff's first comment, the anesthesiologist or echocardiographer for the second especially case should have illustrated the C-sep distance, the risk of LVOT obstruction and SAM forming, and the length of the posterior leaflet and the anterior leaflet should be clearly demonstrated at that time, and hopefully the surgeon will actually see that. So you saw on some of these images how long that posterior leaflet still remained, and again the Alfieri stitch was falling out in the end, because it's often just a single stitch, as I understand it, and so it's, sometimes if you think of it, the tissue bridge, and I think that's what you refer to with the clip or the Pascal device, is much more of a solid. You take more tissue in, and so perhaps it has more stability. Sometimes I actually say in these scenarios, the combination of a stable ring and the clip as in lieu of an Alfieri stitch is the best of two worlds, because you don't have annular dilatation anymore if you have a ring in place.
And what is the role of artificial cords or something when this happens? Or you just do a resection of posterior leaflet and move the coaptation posteriorly? That's the best strategy? Or?
Yeah, I think the best strategy is, as you said, for me, the surgeon, to understand there's a risk of SAM, and at the initial operation, shorten the posterior leaflet by resecting a portion of it. That said, if I do a repair and I have SAM at the end, then I go back and make new cords to the posterior leaflet and pull the posterior leaflet all the way down to the papillary muscle. And that moves the coaptation posteriorly and basically eliminates the SAM.
Okay, so of course, at this point we're considering our options. We know that redo open heart surgery is going to be a very high risk. And so we started thinking about what are our transcatheter options here. So whenever people, hear there's a ring, there's a prior repair, the first thought is, can we do valve and ring? It's not a complete ring. This patient just had a band. And also there's already LVOT obstruction, so that was not going to be an option. So really the big question was, can we do mitral tear? So for our evaluation for mitral tear, one of the first questions we ask is, are the leaflets graspable? To do this, we use 3D imaging. We align our MPR planes on the MR origin, find the MR origin with color on, and then we actually turn the color off. And if you look at the lower right image, if you look at that green plane, that would show us our grasping view. So the leaflets are long enough to be able to do TEER. The anterior leaflet insertion to us may be a challenge because you can see that SAM is going right up against the septum. So that was one thing we had in mind is, are we going to be able to scoop underneath that anterior leaflet? The next thing we think about when considering mitral TEER is what's the risk of mitral stenosis. The mean gradient at baseline was only 3, so we weren't too concerned about that. But whenever there's a repair, even if the gradient's low, we know that there's potentially a risk of mitral stenosis. So we typically will also measure the valve area. Here we got a valve area of 3.3 centimeters squared. So that was a bit concerning to us, especially because we knew we'd have to put a clip in the middle of this valve. But really, there were very limited options at this point, and so we thought this is reasonable to try. So after a team discussion, we said, this is our best option for what we're doing right now. We're not really sure exactly how it's going to go, but again, clip is typically a low-risk procedure, so let's move forward. So as predicted, we aligned our clip right at A2, P2, and we initially couldn't get under the anterior leaflet. You can see we're just kind of pushing it to the side there. After adjusting the AP trajectory, we're able to successfully get under the anterior leaflet, grab the anterior leaflet, grab the posterior leaflet. We eliminated the mitral regurgitation, as you can see there. And as we're assessing the MR result, everything looks great. There's really no mitral regurgitation. We see that the anterior leaflet's been pulled away from the septum. We're not seeing much SAM anymore. Our pulmonary veins normalized. LVOT obstruction's better. Next step, we look for mitral stenosis, and we had a mean gradient of 14. So that was our worry going into this case. Slowed the heart rate down a little bit. We got the mean gradient down to 11. Obviously still high, and this is a younger patient. Mitral valve area by 3D planimetry. We measured the lateral orifice and the medial orifice, the two together, 1.9. Didn't seem like it was the worst number in the world, not ideal, but again, it's kind of the patient was in a difficult spot. Dr. Kapadia, Burkhart, Serge, when you're in these cases and mitral stenosis pops up, what kind of decision making are you using in terms of can we leave this valve with a gradient this high? How do we know if the patient's going to do okay in terms of balancing the treating the MR versus mitral stenosis?
So for me, it is several things that if I see the A wave larger than the E wave, that tells me there's a real bad mitral stenosis. The waveform that you see with the 14 gradient with a very slow decel time, this is bad mitral stenosis, especially if there is no mitral regurgitation and this kind of gradient is happening, that's a bad mitral stenosis. If the gradient is more than 10, that is, again, not super acceptable. So what are the things? Of course, the heart rate, you can decrease the heart rate as we did, but heart rate of 79 to 59, so 59 is not very attainable in the day-to-day practice. So this is, if you are about 10, as I showed you in the literature from the TVT registry, about 10 is a bad news. I would say about 8 even in the anesthetized patient is not a very good number. So if it's at least less than 8, it is reasonable. What can we do about all these things is several things. So, we can take a little bit less anterior leaflet. We can make sure that we twist the anterior leaflet a little bit out. We can put a smaller clip. We can put a clip with a little spacer inside. So all these different things can be tried to eliminate the gradient if there is no other option for this particular patient. But this is a difficult situation for a TEER procedure where, and you can put the clip somewhere different, slightly different, a little bit medial, a little bit lateral, turn it around so that the leaflet has a little bit more mobility. So all these things are possible. And this is the advantage of percutaneous therapy, is that we have the beating heart, so we don't have a penalty to pay. A small penalty that if you get tangled or something, but if you are reasonable technically, you should not get tangled easily, but you can.
Maybe a couple additional comments. I think these are all absolutely important points. Maybe from an interventional technology or approach, I think with more devices coming onto the market and some of them having a little bit more of a give and take and maybe different footprint and taking less of a real estate of the mitral leaflet area is potentially helpful. Maybe taking a little bit less of a grasp or not taking as much leaflet, in other words. And then certainly the patient themselves, what are they planning to do? What is our expectation together with the family and the patient of how active they want to be, and if this is really a rate-limiting step for them. But we have had scenarios where we actually then refrained from leaving the device behind and took it back out and then pursued maybe transcatheter valve replacement or surgical options again.
Yeah, this was a tough scenario. You know, we had quite a bit of a discussion, in the OR that day, trying to figure out what to do with this gradient, and we kind of talked about all these different approaches. Can we try to get a little bit less anterior leaflet? Can we try to cinch it in a bit less? It was very, very hard to get under the anterior leaflet, and because the anterior leaflet with the SAM was being, for us to get under the leaflet, we had to go very, very ventricular. And then to be able to get the posterior leaflet, we obviously had to come up quite a bit. So just technically, it wasn't possible for us to grab, less anterior leaflet because of the way that we had to grab the two leaflets. So, our main discussion at that point was, what are this guy's options? It's if we take the device out, we're back in square one. He's heading towards dialysis and, all these other problems. The mitral valve area didn't seem, terrible. We did have a high mean gradient. I think we actually called one of our surgeons into the room as well at that point and said, hey, let's talk about the overall plan with this guy. We're not super happy with this result, but how can we think about, how can we help this guy? And the thought was, well, if we can at least get him out of this acute scenario, and even if he can tolerate mitral stenosis for a few months, maybe we can make him an operative candidate again. And so that was what we elected to do. We left the clip in place. So you can see LVOT obstruction, we got rid of completely. After we opened up the septum, took everything out, our mean gradient was a little bit lower, down to 9, so that made us feel a little bit better. Again, this was a young, active, healthy guy, so mean gradient of 9 was not great, but it was better than 14 and better than 11. Final T results, we're very happy with how the valve looked overall. Surface echo next day looked great. This was one of actually the fastest turnarounds that we've ever seen in terms of creatinine immediately started going down. Urine output went up, bilirubin went down. And truly the initial plan was like, hey, go home and in a few months come back and have a surgery. And he went home and he felt great. And so 3 years later, he still hasn't wanted to come back for a surgery. His gradient is, still elevated on surface echo. I think it was in kind of the 7-8 range on follow-up. So we're still monitoring him, and obviously, worrying that, just making sure we don't miss the development of pulmonary hypertension over time. But he kind of surprised us all here. So, yep.
Please ask some questions. Slido's working. We're testing it, so no questions yet. I'm going to invite Mauricio up here. Mauricio, why don't you come up over here and you can help lead the discussion as well?
Can I ask a question? So first of all, a comment, because we see that a scenario not that uncommon of patients with failed repairs. So I think for the surgeons, if they don't know how to do it, don't do it. Because the consequences are dear, and this is one case. Secondly, in terms of the management of these patients, Dr. Capares showed actually mortality data. So this patient probably is not only that he feels great, but if it's true that over time there is a mortality benefit, this patient, don't you think, should be considered for surgery, even if he feels relatively well, given the fact that those data that you show with more than 5
so
to 10?
The question, remember those data are the TVT registry data, and there is no comparator. So you say that the mortality is higher in the patients with higher gradient. Doesn't mean that if you remove the gradient, their mortality will be less. This is a leap of faith. It's like having PVCs and we ablate, and then they say the patients will do better. we don't know. Maybe this is the indicator that their valves are not as good, so to begin with, or their whatever the reasons are. So I think you should not take it as an idea to say that we send them to surgery for this particular reason. But when we are doing procedures, we try to attain as little gradient as possible would be, I think, the interpretation of those data. And that's why the primary trial is going on, to say that whether we can compare surgery to TEER procedures. I would say that one other thing is that septostomy is, if the right ventricle is normal, leaving the septum open has an advantage, because like Luttenbacher syndrome or whatever you call it, this is a good thing that you have a little bit less LA pressure, a little bit less gradient, and the pulmonary hypertension will be less. So this is another advantage, I think, to have a little bit of septostomy in these patients. With MAC also, we find the same thing, that when the gradient is higher, leaving a little bit of a hole in the septum, if the RV is normal, helps.
So fascinating case. Thank you so much. That was incredible. So, Dr. Kapadia, you have now 6 different options for TEER devices. You have the Pascals, you have 2 models, and then you have 4 different ones. So what was the rationale for choosing the device? So can you repeat again what device was chosen here?
This was a MitraClip XTR that we ended up using. When this was done, MitraClip was the only device.
The only device.
Yeah, this was before
This was
Pascal
3 years
approval.
ago, but
So would you have changed, the approach to this? And do you think you have gotten a better outcome?
No, because, so again, my personal bias is that if you want to cinch or bring the things together, the clip does a little bit better job than doing Pascal. We have not seen a huge differential in terms of the gradient between the 2 devices. The randomized data, to be honest, shows that the gradient was slightly higher with the Pascal device than with the clip device. However, we like the Pascal for the patients where there is commissural things, where there is not easy to get in and out, where those are the typical reasons why we would use the Pascal device. We are learning also that which is the better device of the 2, but I think in maybe 50-60% of cases, either of them can be used. And in 20-30% of cases, I think you can decide which one is a little bit better than the other. But in this case, I would even today say that we would have done very similar thing with the clip. But we can always try.
Maybe one other question to be specific: the NT versus, meaning the shorter clip as opposed to the XT. Was that discussed, and how would that potentially affect the remaining opening?
Correct. And I think very good question too, that to say that the NT is a shorter clip, so you get a little less bite of the leaflets, and the XT is a longer clip. Again, this particular case, because of the way the anterior leaflet is samming and it was difficult to grasp, so we needed a larger clip. We even had a hard time with the larger clip to get both the leaflets. So we thought that it is better to use a larger clip than a smaller clip. But this is, again, a good question. Sometimes when we try too many things, like say I take it out, the larger clip, then put a smaller clip, try it again, then it doesn't work, put a larger clip. All these things are not totally risk-free, because you can get tangled, you can tear the leaflets, you can cause issues. So at some point you have to decide that what you want to live with. So this is a learning process, I think. But in this case, we decided that we had done enough, so we didn't want to do more, taking it out and putting it another one. But it's a good question.
So we have a question here. So this is going to be for an imager, so maybe Dr. Harp can take a tap here. So the role of pulmonary venous flow in assessing mitral regurgitation post-TEER. So your take on that.
Yeah, that's a great question. Actually, we find it super helpful, particularly when we start with a reverse pulmonary vein flow, because then when you get it normalized, you feel like there has been significant hemodynamic improvement. We also find it to be the most correlated with the pressures. Actually, sometimes we find discrepancy between the color Doppler assessment by echo and then the invasive hemodynamic assessment, which we do for every case. And this discrepancy could be related to the fact that, some left atrium are more compliant compared to others. However, whenever you see a reverse pulmonary vein, typically the LA pressure are quite elevated. Whenever it's blunted, it can be all up. Sometimes we've seen severe MR with like normal pulmonary venous flow, but this all usually translates into normal hemodynamic measurements. So it's, I think, one of the best tools that echo has to correlate with hemodynamic measurements.
So to ask you a question, Serge, what are the other measures you use? So pulmonary vein, of course, do you measure all pulmonary veins or just one?
So,
yeah, go ahead.
No, it's
and other things, what you like to use?
No, it's a great question. So sometimes we see that the pulmonary veins, not all of them are reversed. Sometimes we see one of them being reversed, one of them being not reversed, and then we wonder if it's unlikely to be related to pressures because we assume that the pressure throughout the left atrium should be the same. We then wonder if it's the direction of the jet, particularly in primary MR, which is causing the physical direct impact on the pulmonary vein and causing it to reverse in that area. The other, to get along with Dr. Kapadia about like the other things that we look at in terms of success, of course, is two things. One is the reduction in color Doppler, and then two is the result in terms of like gradient. And then typically what we like to see is the profile of the gradient being, as Dr. Kapadia mentioned before, we don't want to have a high A wave, we don't have to, which translates into risk of MS. So it's not only the number, so the mean gradient of 5 doesn't tell me much, or the mean gradient of 4, it's more the profile. Is it more E dominant? Is it more A dominant? What is the deceleration time? So this is a second factor that we incorporate along with the color Doppler, the pulmonary veins. What we do also, we do look at the TTE intra-op just to see what it correlates with what we will see. So we have like a baseline on what to compare with the TE being with the patient. And most of the time the decision is not relying on one variable, but multiple variables. We have the hemodynamic assessment, we have the V prime that Dr. Kapadia mentioned. So we look at the hemodynamics, we look at the colors, we look at the pulmonary veins, we look at the profile of the mitral valve inflow, we look at the mitral valve area by direct planimetry. So we incorporate all these factors once we decide to release the clip or to add additional clips. So, and one other very important criteria to add additional clips, which was shown in the prior case, is to see if there is residual pathology. Sometimes, especially in prolapse valve or like Barlow kind of valve, you put a clip, you see an excellent reduction in MR, but you see adjacent areas that are still prolapsing. There is no MR, but they are still prolapsing, and you're always wondering what will happen to this. Will it continue? Will the patient come back in few months, few years with recurrent MR? So there is always a discussion, should we just add another clip to stabilize the pathology despite that the MR has significantly improved? And I wonder what other panels, experts on the panel think. When we have like a big prolapse, Dr. Mackinson, we put a clip, the result is excellent, the MR is reduced, but there is still like adjacent segment of prolapse. Do you chase it? Do you leave it? How do you go about it?
That's an excellent question as well. We try to do what we can to simulate what happens in the operating room. If I work with a surgeon in the operating room and there's a remaining pathology left and it's associated with some degree of regurg, I think we both know that over time this will likely become worse and become more of an issue. So if in the percutaneous scenario we do have not a prohibitive gradient at that point, again we also need to calculate in MR severity that is remaining may inform the gradient, because you look at the net flow across the valve and gradient may be higher than you otherwise would estimate, and could actually potentially come down with a second device. And so we try to be as careful, and then selecting in this toolkit of 4 different clips, maybe coming in with a narrow clip next to it to take really care of that pathology. And I think, again, back to my initial talk, that's why it's so important to really fully understand the pathology So you actually know how it looked at baseline, and then once one device is in and there's some remaining jet, you can actually look for that pathology that you identified initially and maybe still see a little bit of a prolapse. So I think that's an important aspect as well.
And to add a comment to that, in the operating room, what we're looking for is less than mild MR. Just like the study that Samir showed from JAMA, where Raj Makkar was the lead author, the more MR you have and the more MS you have at the end of a mitral valve repair, the lower the life expectancy. And there's some good data from the Mayo Clinic from years ago, also more recently from Cedars-Sinai in the surgical population. If you leave 2+ MR, you have a shorter life than 1+ MR, and 1+ MR shorter life than trace. So we aim for less than 1+ or less than mild.
On that note, actually, Dr. Little is going to be here as well. And Dr. Little, myself, and one of our former fellows, we did a study looking at 3D vena contracta in the context of about 155 mitral tear patients at both Houston Methodist and our institution in Seattle at the University of Washington. And what we found is that if we leave more than a 3D vena contracta of 0.27 centimeters squared, so behind, that there's a higher likelihood for the patients to be re-hospitalized and come back maybe for a second mitral tear procedure. So again, scrutinizing baseline and looking at the end to really leave as little behind as possible, very similar to the surgical situation.
Is it a question to...
So we have more questions here, Samir. So
Go ahead, ask the question.
The audience is very active here. So we have a few questions. So one for Dr. Gillinov here is probably from the surgeon. How well does surgical repair work with atrial functional MR and posterior leaflet shortening, hamstringing?
I think the question is, how well does surgical repair work with atrial functional MR?
Yes.
And the answer is very, very well. It's different from ventricular functional MR. So a small annuloplasty, whether a band or a ring, combined with a maze procedure to attempt rhythm control works very well for atrial functional MR. That is one of our operations that I think is very satisfactory.
They are asking about the hamstring posterior leaflet. So, in case does it matter to you?
No, it doesn't matter. When you put the annuloplasty in, the posterior leaflet behaves. You just reduce the AP diameter. It's not an issue.
Is that something you actually see in the OR? Like, do you see, sometimes we see things on echo, but then this is something that you see hamstring in the OR?
Yeah, you see it hamstrung, and it sort of makes a curve and goes down. And once you put the annuloplasty in, that morphology disappears.
Wow.
We have another question here. So Dr. Gillinov and Dr. Kapadia mentioned the team discussion several times. Do you have a coordinated approach to TEER surgery discussions and how your discussions go?
Yeah, we definitely do. Do we have a
It's about the heart team, so the two of you.
Do we have a heart team?
Oh, I was in the call this morning, so from 6:15, because we are surgeons and interventionalists, the only time we find is 6:15 in the morning. So 6:15 in the morning we get together. Today was the day, and we do it till 7:30. So we have an excellent heart team, and everybody is very involved, and we learn from each other. So every day we have similar discussions that what is the best thing to do. So
who are the members? Who are the members in the call, Samir?
What's that?
Who participates in the call?
So on the mitral and tricuspid is Friday morning. So Serge, Randa, myself, Amar, also interventional cardiologist, imaging cardiologist, heart failure cardiologist, EP cardiologist, cardiac surgeons, and even the heart failure cardiac surgeons. So this is as big as it gets. So too many RVUs done during during this meeting, because we have close to 30 people.
No credit though for RVUs.
No credit for these RVUs, but it is a lot of time spent and a lot of mental, and we review all the images. So it's not just talking. So we are bringing up all the echoes and TEs on the teams, and we are looking at all the echoes and CT scans, imaging, everything. So it is a very involved meeting, And I think it is a lot of fun, as you would agree, right? That it is.
So when do you extend that? So you have lots, and there's no shortage of people there in main campus. So when do you extend it to, let's say, a geriatrician or a palliative care doctor? Do you have that situation or just cover for that?
No, because we don't, of course there is a little balance between, because some people just want to talk and delay everything. So this is what we need to be careful about, because, we have like enough patients to see and all that. So we don't need a philosophical discussion. So we are doing very to the point, and if they need a consultation, we consult them. But we are not extending, because there are some people join from other hospitals, they start pontificating, and then we have to cut it short and just keep it on track.
Okay, that's very good. So we have another question. So you mentioned the left atrial pressure direct measures. So I've seen you do these cases, and so the question from the audience is, should all patients undergoing mitral clip have direct LA pressure measurement during the procedure? I see that you do it systematically, and can you explain how you do it and
so I like to, for the Pascal device, there is an additional channel, so it has a good pressure, so you don't need to put additional catheter. But for the mitral clip procedure, I actually put an additional catheter from the groin, same groin, just one below. So I stick the vein underneath and put a 4 French or 5 French, 4 French typically catheter in the pulmonary vein in all patients. So one thing I personally also think is helpful, we always talk about the LA pressure that we improve, especially for the secondary MR. That improvement in the cardiac output is also very important in my mind. And we don't have a very easy measurement of improvement in cardiac output. So we can measure in the echo the LVOT velocity or something like that to measure the forward stroke volume. But typically we do not pay attention to the cardiac output. So Serge did an exciting study to say that we can see the dicrotic notch, and if the dicrotic notch moves further or down, that means the cardiac output increased. And that can also help us to say that the procedure was a little bit more efficient or successful. So I think we have to come up with some idea, because we are not putting right heart caths and all those things in these patients. So whether when we do the clipping procedure or TEER procedure, are we really improving the cardiac output and decreasing the filling pressures? This would be an exciting part to say that what is efficient or not, especially in the secondary MR, because in primary, of course, it increases the cardiac output.
Well, thank you so much. I think we're up to the bottom of the hour, so we are going to wrap up this session and thank all the speakers for wonderful presentations and an amazing case.